Hi, everyone. Lovely to be with you today. And I'm also a morning person, so we're just going to do our best at this point. I'll try to stay on track. So I was thinking about this talk, and I really love that picture of the maze before. I think Dr. Sharon saying that healthcare is a maze. So I thought I would talk to you from the clinician perspective of a little bit about what's going on in that maze and how the clinicians are thinking about things. All right, there we go. So with that, just a quick overview of what we think of the spectrum of care. So when we're sitting together with a case conceptualization, what that's looking like. And then also highlight some key areas where I think we could really make a practical difference. Like this is low-hanging fruit that could probably happen now or sooner. Well, probably now, they're going to go sooner than that. So a couple of acknowledgements. I want to recognize the MDH Center for Suicide Research and Prevention, who is doing some wonderful implementation science work. So really trying to bridge going from research to clinical practice, where there's often such a gap in things actually happening, and who provided funding for one slide that I'll show you today. But then also just acknowledge the perspective this is coming from. So I am primarily a clinician. I've worked in outpatient care for the majority of my professional career. And my other hat, in addition to suicide prevention, is in addiction work. So particularly with substance use disorders and more recently with behavioral addictions and building programs for home base that in many ways nest substance use care into PTSD or TBI care rather than having that as a siloed clinic. So you'll notice that I draw a lot of examples for that as I'm going to go through this. So this is a very simplified, rough representation of, like I said, what's going on when all the clinicians get together. We're looking at a case for someone who is, we think maybe at risk for suicide, and how the logic often unfolds. Maybe not necessarily how it should always unfold, but what it tends to look like. So you'll notice in the spec, we get, on the horizontal, we have clinical care intensity. On the vertical, and there's already some question marks, we have severity. So a lot of times in traditional mental health care, there's this very almost overly simplified thinking that if someone's at lower risk to higher risk, and that there's a spectrum there. And then, the lower risk people, right, might get matched with a less restrictive treatment. So, less intensive treatment, that they can do something a little bit more accessible. Whereas as we move further along the intensity spectrum, right, we must have to match that in some way. We have to go more restrictive. We have to go more intense with the care if we're seeing a more severe presentation. And so I'm going to go through kind of ideally what this would look like, and then we'll talk about how even this logic is a bit fundamentally flawed. So at the most basic level, we have what technically you might not consider even a clinical intervention, which is the peer and community support. And other folks have really done a lovely job explaining this. I'm going to talk more about this later, but really a direction we're going in. But having folks who are actually living the day-to-day have the experience being the forerunners. And so the times where this gets nested into clinical care is sometimes like home base, we have veteran outreach coordinators who are part of our day-to-day. Or there are models out in the community where there might be a clinician or a therapist who is supervising or consulting as needed. We go a step up. We're still technically not in mental health care yet. Now we're thinking about these brief interventions that sometimes get nested in other medical settings. So thinking about oncology, primary care integration. So we have maybe there's a social worker or a psychologist or someone from behavioral health who gets called in. And we're thinking from a suicide specific lens, it might be that they're doing one of those brief interventions like the crisis response planning, safety planning, something like that, or really brief protocol, a couple of sessions. And so they might get a referral without having to leave that setting. You bump it up a notch, and the idea is people could step up or step down from these levels, is we think about what's more traditional mental health care. So that is going to be what you think about as that once weekly to once monthly individual therapy, group therapy, medication, maybe couples therapy. And as Dr. Bryan nicely pointed out and some other folks, right, this isn't always necessarily suicide focused though. As someone who went into grad school doing suicide-focused therapy, I think I assumed that was going to be more prevalent, and it's really hard to come by. You don't actually see a lot of those suicide-specific approaches coming up in general outpatient clinics. But nonetheless, there are some benefits to that we'll talk about. You go up another step and you have people refer to as the IOPs, PHPs, which really are more of the extension of the outpatient. Everyone's still going home at night, but you're primarily doing group therapy, and it's, might have some medication attached to it, or it might be individual therapy, but really it's a lot of group work and building skills. And so there isn't too much in this category or in the residential program, where now we're, again, going more restrictive. You are now in a setting where you're there overnight, you're living there, you probably have some freedoms, but you're generally in a more protected setting, kind of away from the day-to-day. You might see some DBT programs, but this is a thing that is very common, these two in black that are very common in the substance use community. We don't see them very frequently in the suicide prevention community or really other mental health diagnoses. And then we get all the way to the talk, which I think folks are very familiar with, which is inpatient hospitalization, where there may be suicide-specific care in there, but that's not often the norm. And so I said there were some fundamental flaws with that, and that's going back to that original suicide risk severity one, where there's this assumption, right, that people go from lower to higher risk, and that it's this kind of nice trajectory. When in reality, maybe if someone has chronic risk, think of a chronic versus acute, maybe that applies a little bit better, but when we think of acute right this moment risk, there's been a lot of studies here where they have folks check in every couple of hours with the intensity of their suicidal thinking. And there have been studies where they look at suicidal behaviors and how quickly it takes for someone to first have that initial thought that they're going to act and then act on the impulse. And it is not this gradually building line for many folks. It is a very rapidly fluctuating cycle. So at any given time, it can really be moving. Right? Someone within the course of a couple of days can feel very, very strongly that they want to die, and then hours later can feel quite differently. Even if they haven't resolved the ideation completely, just the intensity and the degree of that. So it's really not, this nice, okay, it's low, medium, high, and different degrees in between. It's where someone is at right now. Which brings us then to, what we tend to do. So when we think of inpatient hospitalization, that is really become synonymous in the clinical world of, if you hear the word, those word association things, like those games that you have to you say a word and what comes next. If you say high risk for suicide to a clinician, probably the first thing that pops into their head is hospitalization. And that's maybe not always the best model for that, right? So what ends up happening, the key strength with hospitalization from a clinician's perspective is often simply that it is often the most reliably accessible. Not necessarily convenient, right? We're not saying this is people's preferred route of care, but working in a national program, when you have people from different states, different insurances, different things going on, we can normally guess that there is a hospital and emergency room. And so if we want to get them seen quickly, that is often the path of least resistance to getting some form of care right now. And so I think it's become overly, when we go into shortcomings, right, overused sometimes for that. I was listening to a talk a couple of weeks ago. They're talking about using AI in emergency departments. And one of the former heads of the psychiatric service in the ED said, there are times where we do feel like we could go with the less restrictive level of care for someone, but there's nowhere that can take them quickly. And so between giving them no care and doing an inpatient admission, that feels like the safer route. So sometimes it's purely a lack of options that is leading to use of an inpatient admission versus that it might actually be the best fit in terms of what the drivers are. Because when we think of what a good inpatient admission is, it often means that, you may have heard that term drivers, right? Like, what is the thing that in that moment is actually driving the person to want to die so strongly? And so I've seen patients do wonderfully in inpatient admissions when those two things align, right? Maybe they needed quicker access to a medical intervention like ECT, or they wanted to do ketamine. An outpatient that would take months to get into. Or maybe they needed a period away from things just to reorient, just a safe space to be for a couple of days to reorient. And maybe that inpatient unit did a wonderful job collaborating with their outside care team and their family and with the individual themselves. And in that case, it can be a really helpful experience. But a lot of times that's not what it's being used for, right? It's being used because someone said this person's at high risk, and that is what we were taught to do when the word high risk comes up. And then, which can then be problematic with unrealistic expectations, right? Because if you didn't have that right fit to begin with, then the individual or the family might say, they were in there for 72 hours to a couple of weeks. Why aren't they, changed on the other side? Why are things still not working right? And so in addition to maybe not being the right fit, we also have to think of, the change that's possible in a short period of time. And if given the right interventions, that can be massive. But if it's really just having a safe space to be for a couple of days, there might not have been that new learning, that new idea of when this emotional state comes up, or when this stressor arises, or when this thing, and I think other folks have made this point, it really doesn't necessarily be mental health driven, but when this comes up, how do I respond differently next time? And how do I practice that and build those new pathways? If that hasn't happened, then we're probably not going to see much change, because there has been an opportunity to learn a new way of doing things. And then I don't think this kind of goes without saying, but it's reactive versus proactive, right? It's not a very appealing model. When we think about, just even as consumers, the things we like to use or not use, we'll talk later about there's a lot of barriers to going in. And so people are often in a pretty, dire place if they are voluntarily admitting or if someone has involuntarily admitted. So we're really missing a lot of the care spectrum by overusing this. So I'll talk more about this, but in the substance use world, we often talk about this notion of multiple pathways to recovery. That the idea is that it's not always one route to getting better. It can be multiple routes, it can be a combination of things, that there isn't necessarily a wrong path, but more of figuring out what's going to be right for each individual and really personalizing it. And that's not maybe always the message that we're getting here. And I'll talk more about this in a moment, because I am trying to be mindful of time here. So let's go back. So when we get to outpatient care, again, I think the main strength here is we mentioned that how does change happen? And you normally have more touch points. You have a chance to build that therapeutic relationship. There is that chance to try out those new strategies, to figure out what is it that's actually driving this behavior and to do things differently. But in addition to it being very difficult to actually find when we're trying to refer someone or when we're trying to do it even in-house, sometimes we run into these hesitations. And so this probably doesn't look new to folks. This is when I do trainings for the incoming class. I'll often show these slides and I'll have them think for a minute. And I'm guessing that everyone in this room is familiar with a lot of these, right? Why I don't want to go see a mental health care professional, definitely don't want to go inpatient for this. Because people have what are actually pretty legitimate fears about folks over or underreacting to their circumstances. And then just going back to that too, and we don't always have a great pathway for addressing these fears. Because for some folks, this is a possibility. It's normally less so than they may think, but it's very clear that these things, they can see very clearly how these things could happen, but they often don't see very clearly, how would I build back from that if that were to happen to me? And so I think that is one opportunity that we have for anyone who is involved in those kind of roles, is thinking through a clearer system of how do we know when someone is safe to have, if their security clearance actually would be affected by this, and if so, when it's safe to give it back. And there really aren't great guidelines around that for us to share with patients and help them feel more secure. But then we think about, well, what are we actually saying when we're saying comprehensive clinical care in an outpatient setting? And every year I add more bullets to the slide, and I've thought of a few more since sitting here today and listening to all the great speakers. And you don't have to read all these. The point is that there's a lot of them. And so a lot of times folks are getting a 1-hour training, very brief trainings on things. Or maybe they're getting a 2-day training, but there's 12 bullets on there. So even if we're spending an hour for each bullet, maybe they've heard about it, but they probably haven't gotten a chance to really practice it. And even on someone's caseload, it's, you might have folks, suicidal thoughts are very common, but someone who would merit doing a suicide-focused treatment or benefit from that may be a very small part of your caseload, maybe one person every once in a while. So your chance to really hone these skills and get comfortable using them may not be readily available. And so what we see then when we ask the providers, what are your concerns? This is what clinicians are often telling us. They really want to do a good job. They really want to keep their patients safe. They are terrified. They feel a lot of responsibility that if anything bad happens, that's the expectation, is that folks work really hard to get folks to connect to care. And so when they get here, it is my job to really make sure that this person stays safe. So there's a very big fear that anything bad will ever happen to our patients. But then also there's that legal piece. There's that legal piece of like, well, what happens if I make the wrong decision? What happens if I go too restrictive and that somehow harms the patient? What happens if I don't go with the more restrictive option and something bad happens? So there's a lot of doubt, because even though the expectation is sometimes that clinicians are able to predict, all the scientists said that we're actually not great at predicting exactly who will do what at what particular moment. And then back to that list, right? Sometimes the scope is just overwhelming. Folks who may not be doing this every single day, and then they're like, okay, I'm supposed to do all this stuff. Which one do I do first? Did I hit everything on the list? What happens if I miss something? I have another patient, the psychiatrist in particular, right, might have 20-minute sessions, probably longer than I should have been talking right now. So they're like, all right, did you get through all this list by the time I'm supposed to be off the stage? And so they feel a bit overwhelmed. And so when folks feel overwhelmed, when folks are worrying about the what ifs or the uncertainty of the situation, we see what we see in trauma work a lot, where sometimes it's avoided. I think someone mentioned this earlier, right? If the option is, do I do something that is risky versus I do something that would at least protect me from being blamed from it, or me holding the responsibility for it, it's pretty human to avoid it. And so sometimes that looks like transferring responsibility, the inpatient admission with the higher risk, what's considered a higher risk patient. Sometimes it looks like more the check the box of like, yes, I'm doing all the forms, I put in all my documentation, I can say that I said the right things, but did you actually connect with the person? And then sometimes it's more of this power struggle. I'm not gonna go into no suicide contracts because of time, but just getting a promise, like promise me you won't do this. But again, without giving the skills, well, what are you gonna do instead when you feel this way? So we end up doing things to try to make ourselves feel better about the situation, but in reality, it may not be treating the situation in the most therapeutic manner possible. So this is my one research slide for today, which is, we actually asked this. We did a quick video for a couple of years when working with providers at MGH. So people who work with military and veterans, but also who work with the general population. And we're trying to get you to use the Stanley Brown safety planning intervention in a thoughtful way, which is an evidence-based practice similar to crisis response planning. And we said, we kind of got a sense of who's using it so far, who isn't. Originally, they told us we really want this in the medical record. If you put this in our medical record and make this accessible, that will make it easier for us to use it. So we worked with the medical record people for a couple of years, and we finally got that, right? We got an accessible version. And we made them a little YouTube style video, and we had 289 clinicians. So these are seasoned psychologists and psychiatrists. These are not the trainees. These are folks who have been staff with the program for at least half a year, who are eligible for these quality improvement incentives. So basically they get like kind of a lopsided bonus if they do this like 15-minute training. So it's a pretty good deal. And so we will have them watch this video. Here's how you use it in Epic, in the medical record. And then as part of that, we say, at the end of when they finish it, we ask them, we asked them a whole bunch of things, but this one just shows, we said, what would make it more likely for you to actually use this, for you to make this part of your practice? And we had some ideas, but what they ended up saying, I'm not even going to try with the laser pointer, but that you see the blue are the psychiatrists and the orange are the psychologists. And this is more of a psychologist intervention. It's brief, meaning one session, but to do it really well, it takes about 40 minutes. 45 minutes or so. So what the psychiatrist said is they really wanted to understand the workflow. Practically speaking, they might always have time to do this intervention. So they really wanted to understand who is, if I'm working in a team, as many of them are, what's the best flow of this? Is this something I should be responsible for doing? Is this something that someone else on my team should be doing? Whereas a psychologist, 99% of them, right? We had 170 psychologists. 99% of them said, I want to understand malpractice liability. I don't feel like I understand truly what that looks like. And if I understood that, that would make me feel a lot more comfortable using this intervention. And then they also mentioned, I would like toolkit there refers to telehealth toolkit because, again, that opens a whole can of worms about how you operate. And then consultation and training for the psychologists who probably see themselves more as doing this as an intervention designed from psychologists, so they're kind of naturally have more affinity with it. And the thing with training, right, we're not just talking a one-time training. We're talking, this is something that if we're going to become more specialized, is we really want to get good at this, some kind of ongoing consultation. And so which brings us back here, right, when we foster an approach versus an avoidance, the fear and the uncertainty drives the avoidance, just like it does for any other type of avoidance that we do. So if we want approach, we want to build confidence. We want our, when folks are coming to us, we don't want our clinicians to be afraid to treat folks at suicide risk. I can't think of a more appropriate place for someone to tell someone that, right? So we want them to feel like they're confident, they know some things that they can do, they have an idea of how to guide, they're not going to be penalized for doing their best to be helpful. And so addressing some of those concerns that they mentioned, giving some knowledge on what the legal ramifications are and how they can maybe satisfy those, but also what's best for the patient, and actually hopefully also what's best for the patient. Providing some kind of way to fund ongoing consultation, both money but also time, to make this a priority is a big part of what I think would move it forward, and clinicians actually doing some of these practices that we already have, but just really aren't implementing to their max potential. I'm actually going to stop there because I'm guessing I'm over or right at time right now. Yeah. So just really exciting. Peer support is lived experience is definitely where the field needs to go. My only caveats in having worked with building recovery coaching into our program is that I would love to see a system similar to that for folks who are doing lived experience type work with suicide prevention. This is heavy work. Most of my patients, frankly, are already doing some of this work with all their friends. And so I get concerned about their burnout and them becoming the clinician, them losing sleep because they're taking 3 a.m. phone calls many nights. So as we're thinking of doing lived experience, that's the main thing I would just take away from what I've learned through supervising recovery coaches, is just really being mindful that their self-care and their boundaries are being respected, and that they're being taken really good care of as they're taking care of others. So I'll leave it at that. Thank you so much for your attention and time.